Morning, everyone. We will be discussing carcinoma ovary today. Before starting, we will be covering the topic under following heading: basic introduction about ovarian cancer, risk factors, histology, pathology, and mechanism, clinical features and staging, and management of germ cell tumors. So, ovarian cancer is the second most common gynecological malignancy in United States after endometrial carcinoma. Around 22,000 are estimated other new cases with 14,000 deaths. It is the fifth leading cause of cancer death in women. And average lifetime risk is 1 in 70, with median age of diagnosis being 63 years. And greater than 80% of the women are diagnosed after age of 40. It is highly curable if diagnosed in early stages, but 75% present with stage 3 and 4 patients' disease. So this is the ovarian cancer specific incidence and rate, which is progressively increasing as the time is passing. Risk factors is that incidence increases with age. And if there is a positive history for breast, uterine, colorectal, ovarian, and mainly in first degree relatives. Other includes early menarche, late menopause, nulliparity, excessive gonadotropin secretion, infertility, estrogen replacement hormones, polycystic ovarian disease, or pelvic inflammatory disease. And other modifiable factors which includes obesity, low fiber diet, saturated fat, red meat, and talc powder. So these are the various risk factors. So strongest risk factor is family history of ovarian carcinoma, and nearly 20% of them are familiar. Yet only 5 to 10% of these tumors result from a known genetic disposition, 1.8% for 1-degree relative, 5% for 2-degree relative. Histology. As we know, ovaries are derived from embryonic yolk cells, which has two parts, outer cortex and inner medulla. Cortex, which is covered with mesothelium, and medulla consists of stroma and maturing follicles. Follicle give rise to ovum germ cells, and stromal cells produces steroid hormones. Mesothelium forms epithelial covering of follicular cyst, and these type of cells give rise to germ cell tumor, sex cell tumor, and epithelial cell tumor, respectively. So this is the diagrammatic description. Most common are epithelial carcinoma, which constitute about 85% of the total cases, under which it includes serous, endometrioid, mucinous, clear cell, transitional, mixed epithelial, and undifferentiated. Germ cell constitute about 10%, and sex stromal cells constitute about 5% of the total cases. So coming to specific based on pathology, papillary serous, it is the most common type of epithelial ovarian carcinoma, and it may contain samoma bodies and is often associated with CA125 elevation. Endometrioid histology, it is associated with endometriosis or an independent uterine cancer of similar histology. It may occur with early stage disease in younger patients, all through advanced disease is also possible. Mucinous, it may be associated with pseudomyxoma peritoneae, and CA125 levels may not be raised. It is relatively chemoresistant, and differential diagnosis of mucinous ovarian tumor includes metastatic disease from an appendix. Clear cell, it is most chemoresistant of all, and it contains hobnail cells with cleared out cytoplasm due to glycogen, and associated with endometriosis or hormonally mediated hypertrophy. Patterns of spread. It's exfoliation mainly into the peritoneal cavity, then lymphatics mainly into the pelvic or para-aortic, but inguinal also at risk through round ligament. Direct extension, most common to fallopian tubes, and hematogenous, which constitute nearly 5%. 90% of the recurrences occur within 5 years, and 85% of relapse are intra-abdominal. And So this is the mechanism of ovarian cancer metastasis, which is a transcelomic dissemination in which the cancer cells are lose cell-to-cell contact and exfoliate into the peritoneal cavity. And then they float into the peritoneal cavity and are carried all over the peritoneal cavity. And then it attached to the peritoneal organs like omentum and formation of a metastatic nodule called as omental nodules, and then hematogenous metastasis, which includes invasion and intravasation through blood vessels, transport of circulating cancer cells through blood vessels, extravasation from omental capillaries, and formation of metastatic tumor in omentum. So, if the patient present to us with suspected carcinoma ovary, we should get following investigations done, which includes history and physical examination of patient and the family, CBC, LFT, RFT, CA125, which is almost elevated in nearly 80% of the epithelial tumor and may serve as an early marker of disease recurrence. CA 19.9, low sensitivity but may be positive in GI and Mullerian tumor. CEA elevated in nearly 58% with stage 3 disease. Alpha fetoprotein and beta HCG for germ cell tumor. So CA125 is most commonly elevated in epithelial ovarian carcinoma, CEA in mucinous ovarian carcinoma, HCG in embryonal and choriocarcinoma, inhibin A and B granulosa cell tumor, lactate dehydrogenase dysgerminoma, and alpha fetoprotein in endodermal sinus tumor or York sac tumor. Followed which transvaginal ultrasound should be carried out, CT and MRI of pelvis, cystoscopy, sigmoidoscopy, upper gynoscopy as clinically indicated, and pre or percutaneous assessment of ascites or mass not recommended as it may lead to tumor seeding along the tract or peritoneum and delayed surgical staging or management. So this is a diagrammatical deception in ultrasound, CT, and cystoscopy. Clinical features with which patients present to us include abdominal pain and bloating, irregular vaginal bleeding or discharge, adnexal mass, GI symptoms, and are usually associated with advanced stage. Thank you.